Welcome everyone to today's webinar. I am Tracy Cook with Sachs Healthcare Communications, and I'll be your webinar producer for today's webinar on Positional OSA Overview and Clinical Approaches. Our moderator for today is Steve Coughlin. He is currently the Clinic and Market Access Lead for the NightBalance product at Philips Respironics. He is a PhD from the University of Liverpool, which focused on the cardiovascular and metabolic consequences of OSA. He has over a 15-year career in industry. He has managed over 100 international industry-led studies and collaborated on numerous investigator-initiated studies. He has published over 10 articles in peer-reviewed journals and presented at numerous national and international medical conferences. Steve, welcome.
Thank you, Tracy, for that very kind introduction. And thank you, Philips, for providing support for this educational activity. The title of today's webinar is Positional OSA, Overview and Clinical Approaches. We are very fortunate to have two extremely qualified speakers today presenting on this very important and timely topic, Professor Raphael Heinzer and Professor Nico de Vries. Professor Heinzer is currently Associate Professor, Chief of Medicine, and Director at the Center for Investigation and Research in Sleep at the University Hospital of Lausanne. He is the past president of the Swiss Sleep Society and a board member of the Swiss Pulmonary Society. Professor Heinzer has collaborated on numerous international sleep studies with counterparts in the US, Canada, and the EU. He has published over 100 articles in peer-reviewed journals, as well as the author or co-author on several textbooks and book chapters. A highly sought-after speaker, Professor Heinzer has presented at numerous national and international medical conferences. Professor Nico de Vries is ENT specialist at Ogilvy West Hospital in Amsterdam, the Netherlands. His special interest is diagnosis and treatment of obstructive sleep apnea in adults, in particular, alternatives to CPAP. Research topics include drug-induced sleep endoscopy, implants, OSA surgery, positional therapy, hypoglossal nerve stimulation, and combined treatments for OSA and bariatric surgery, OSA and anesthesia, and OSA and biomarkers. Since 2014, he is a guest professor at the University of Antwerp, Belgium, and since 2016, professor of dental sleep medicine in Amsterdam. He has over 190 publications in international and national peer-reviewed journals, 70 book chapters, and now over 300 presentations. Professor Heinzer has disclosed the following. He's received grants from Ligue Pulmonaire Bordeaux and has been a consultant for both NightBalance and Dream. Professor de Vries discloses the following. He's a medical advisory board member for NightBalance, has been an investigator for Inspire and Jazz Pharmaceuticals, a consultant for Philips, Olympus, and the A.E. Mann Foundation, a shareholder at NightBalance, and has an inventor patent on devices, systems, and methods for monitoring sleep position. I would like to mention that this activity is accredited for continuing education. For physicians, a link to obtain CE credits will be available at the conclusion of the webinar. This activity is jointly provided by Synaptive and Sachs Healthcare Communications, and support for this educational activity has been provided by Philips Healthcare. For nurses and respiratory therapists, this educational activity is approved for 1 contact hour. And now, it is my pleasure to introduce Professor Raphael Heinzer.
Thank you, Steve, for this very kind introduction. It's my pleasure now to present the first part of this webinar. So the learning objectives will be first to define positional OSA and the associated level of severity. Second, to discuss the treatment options in the different levels of OSA severity. And third, to differentiate between old forms of positional therapy and the new smart positional devices. So the positional sleep apnea has been first described by Cartwright in 1984. She defined it as a decrease in the apnea-hypopnea index, or AHI, by 50% between the supine and the non-supine position. For example, this man is sleeping on his back. He has an AHI of 30 per hour, and it has to decrease below 15 to be considered as a positional sleep apnea. And this definition was also accepted by the American Academy of Sleep Medicine in 2007. We can also define the exclusively positional sleep apnea when you have not only a decrease by 50% of the apnea-hypopnea index between the supine and the non-supine position, but also a return to normal values, for example, below 5 per hour in the non-supine position. So in this person, sleep apnea occurs exclusively on the back. So the first question we can address is, what is the prevalence of positional sleep apnea? There was this first study by Ari Oxenberg from Israel, who studied more than 500 OSA patients and found that 300 of them had positional sleep apnea, or PP positional patients, which represents about 56% of this group. And the definition he used was the same as Cartwright, a ratio of 2:1 in the AHI. He then looked at the characteristics of the positional patients, PP on the left, and the non-positional patients, NPP on the right. And you can see here that positional patients are a little bit younger. They have a lower weight and a lower BMI, body mass index. He also found that the apnea index and the respiratory disturbance index tend to be lower in positional patients compared with non-positional patients. However, the minimal oxygen saturation in REM and in non-REM tends to be higher in these patients, which suggests that they have a milder form of the disease. Another interesting study is the one from Jeffrey Mador, and he took a slightly different definition of obstructive sleep apnea. It's the exclusively positional sleep apnea definition, where you need not only a ratio of 2:1, but also a return to normal values, for example, less than 5 per hour in the non-supine position. And so for this exclusive positional sleep apnea, he found a prevalence of 49.5% in mild sleep apnea. It decreased to 19% in moderate sleep apnea and went even lower for severe sleep apnea with a prevalence of 6.5%. And we can easily understand that this prevalence will become lower because it's more difficult to reach AHI below 5 when you start with an AHI above 30. Then he looked at the characteristics also between the positional and the non-positional patients, and he found no difference for the age, for the BMI, only the neck circumference was smaller in positional compared to non-positional patients. Another interesting study focused on a patient from Asia, and they also found a fairly high prevalence of positional sleep apnea of 75%, so 3 patients out of 4 were positional, and the exclusively positional sleep apnea was found in almost 40% of these patients. They, however, found no association of POSA with daytime sleepiness, depressive symptoms, anxiety, or health-related quality of life. The main characteristics of these patients were a higher age, so they were slightly older. Body mass index tended to be protective, so the higher body mass index tended to lower the risk, and the apnea-hypopnea index tend also to lower the risk. So the lower the AHI, the more likely were these patients to be positional. So if we summarize the prevalence of POSA and exclusively POSA patients, the different studies found a prevalence between 56 and 75% for POSA, and between 27% and 47% for exclusively positional sleep apnea. When we look at the determinants of POSA, we found lower age, lower BMI, lower AHI, and for some studies, a longer mean sleep latency test, meaning that they are less sleepy than the others. So these studies were performed in a selected clinical population using different types of sensors to assess breathing and different scoring criteria. And as you may know, the technology has evolved over the year. For example, the first studies used a thermistor to assess the breathing, whereas most recorders now use nasal pressure, which is much more sensitive, especially for hypopnea. Scoring criteria have also evolved over the last 20 years. And for example, the currently recommended criteria by the American Academy of Sleep Medicine is more inclusive than the one that was used in 2007. So the question we want to ask now is, what would be the prevalence in a general population sample using current recording techniques, nasal pressure, and scoring criteria? So in order to answer this question, we have analyzed a large population-based cohort called HypnoLaus, in which more than 5,000 patients had a full clinical workup. They also answered various sleep questionnaires. 4,000 of them had psychiatric evaluation, and 2,162 of these subjects randomly selected from this population, who were aged between 40 and 85 years old, had a full polysomnography at home. So this polysomnography included the standard parameters such as electroencephalogram, electrooculagram, submetal myogram to define the sleep structure. We also assessed respiratory airflow using nasal cannula, thoracic and abdominal movement to assess the presence of respiratory effort, pulse oximetry, electrocardiogram, right and left, leg EMG, and body position, obviously. So the subjects came to our lab in the late afternoon to be equipped with all these sensors. Then they return home, sometimes with the public transportation, as you can see here. So this person has the recorder on her already, and she goes to her home to sleep in the usual environment. And she brought the machine back to our lab in the next day, the next morning, in order for us to analyze the data. So overall, we recorded 2,162 patients. The mean age was 58 years old, half males, half females. Body mass index was slightly over 25. Epworth score was 6.2, and neck circumference was almost 37. Overall, they slept for 6.7 hours with a sleep efficiency of 85%. Sleep latency was between 17 and 18 minutes, and wake after sleep onset, so the time awake between the lights off and the lights on in the morning, was 17 minutes. So we were very surprised to see these numbers. Using the current very inclusive ASM criteria and a highly sensitive sensor in this middle to older age population, we found a very high prevalence of sleep apnea, especially when you consider an AHI above 5 as a threshold. But even if you consider above 15, which is considered as moderate to severe sleep apnea, you see that 49% of these middle to old age men and 23% of the women in the same age range have some significant sleep apnea. So this is obviously higher than what was reported before with other techniques. When we focus on sleep apnea syndrome, which includes not only sleep disordered breathing, but also sleepiness, defined as an Epworth score above 10, you find that you can see that the numbers are slightly lower. For example, 11% of the men and 4.8% of the women, if you take a threshold of 15 or more, which is still a little bit higher than what was reported, for example, in the Wisconsin sleep cohort study. So now how about positional sleep apnea? So if we take a threshold of 5 or more of the AHI, you can see in blue the prevalence of POSA, and in red, the prevalence of exclusively positional sleep apnea. And we have, as it was shown in previous studies, about 3 patients out of 4 who have positional sleep apnea, and about 1/3 of them who have exclusively positional sleep apnea. When you take higher threshold, we see, as expected, a decrease in the proportion, not only in the positional sleep apnea, but even more in the exclusively positional sleep apnea, because, as mentioned before, it is more difficult for severe patients with an AHI above 30 to return to a value below 5 per hour when they move from the supine to the non-supine position. That's why this prevalence decreases. Now, if we change a little bit the definition of exclusively positional sleep apnea, when we take a normality threshold of 10, for example, or 15, it means that you only have to return to an AHI below 10 or below 15 when you're not in supine position. Then you see that the prevalence tends to increase with this other threshold. Interestingly, women tended to have a higher prevalence compared to men. Now, if we look at a multivariate analysis of the determinants of positional sleep apnea, you can see that higher AHI tended to be protective. Or in other words, a lower AHI was associated with a higher chance of having positional sleep apnea. Same for BMI. A lower BMI increases your chance of having positional sleep apnea. However, a larger waist to hip ratio, WHR, which reflects the abdominal obesity, tended to increase the chance of having positional sleep apnea in men. Now, if we focus on exclusively positional sleep apnea, we see the same. A lower AHI is associated with a higher chance of having positional sleep apnea. Same for BMI, especially in men. And interestingly, a lower malampathy tended to be also associated with positional sleep apnea in postmenopausal women. On this figure, you see the relationship between waist to hip ratio on the x-axis and the apnea-hypopnea index on the y-axis. So the black dots are supine AHI and the red dots are non-supine AHI. And you see that for men, premenopausal women and postmenopausal women, black dots, supine AHI, tend to increase and be a little bit higher than the non-supine AHI. Interestingly, if we focus on men, you see that this increase really is different for supine AHI compared with non-supine AHI, especially in men, meaning that the increase in abdominal obesity has a greater impact on AHI than in supine compared to non-supine AHI, and we will try to understand why a bit later. So the conclusion for these first analyses is that among OSA patients, POSA represents about 74.6% of our population, and exclusively positional sleep apnea 36.1%. And the main characteristics that we found was a lower AHI, lower BMI, and a greater abdominal obesity, but exclusively in men. Now, how about the pathophysiology of POSA? As you all know, gravity is very important because it tends to put your tongue backwards when you lay supine, and your jaw also will move a little bit backward, which will tend to occlude your pharynx. And the pharynx is a very important part because it has no rigid structure that will prevent the closure of the upper airway. However, if we take the nose, there is a bone around the nose that prevents it from collapsing, and the same for the trachea, where you have rings around the trachea that prevent it from collapsing when there is a negative pressure inside the respiratory tract during inspiration, for example. And we saw before that abdominal obesity was also a problem, especially for men, and we will try to understand why. So if you look at this figure, you can see that when we lay supine, if we have a large abdomen, it will tend to move your diaphragm upwards, in a more rostral position, which will decrease your lung volume. And when we decrease the lung volume, we also decrease the traction of the mediastinum on the pharyngeal walls. So if you have a flexible tube, a highly compliant tube like the pharynx, and you pull it from downwards, it will make the walls less compliant. However, if you release this traction, like when we have a decrease in lung volume, it will make it more collapsible. So we hypothesized that the decrease in lung volume could also play a role in the collapsibility of the upper airway. And in order to demonstrate this effect, we used, when I was working in Boston with Professor David White, an iron lung to change the lung volume in sleeping patients. So this iron lung is a rigid chamber in which you can modulate the extrathoracic pressure. If you lower the pressure inside this chamber, it will expand the chest and increase the lung volume. If you increase the extrathoracic pressure, it will compress the chest and decrease the lung volume. I show you here an example. So the first channel is the extrathoracic pressure. And you can see that we slowly increase this extrathoracic pressure. When we do that, you see that the rib cage diameter and the abdominal diameter tend to decrease. And because this was calibrated, we can say that this represents a decrease in 360 cc in the lung volume. When we do that, you can see that the epiglottic pressure becomes more and more negative when we decrease the lung volume. So it means that this person is doing more and more effort to breathe. And despite this increase in respiratory effort, you can see that the flow doesn't increase, but decreases. So when you have a higher delta pressure with a lower flow, it means that the resistance of the upper airway increases. And this is indeed what we found. So you have on the x-axis the lung volume. 0 is more or less in the middle here. And you can see that when we decrease the lung volume, the CPAP level required to keep the airway open tends to increase. However, when we increase the lung volume, the upper airway becomes more stable, and we can use lower CPAP level to keep the airway open. So there seems to be a direct effect of the change in lung volume on upper airway collapsibility. When we increase the lung volume, we also saw that without CPAP, we could decrease the apnea-hypopnea index, 3% oxygen desaturation, and the arousal index. So there seems to be to have a direct effect on the apnea-hypopnea index. In this very interesting study, Justin and his colleague assessed the functional residual capacity, which is the lung volume that occurs at the end of the expiration, just before the inspiration. And they measured this FRC in 3 different groups of patients who were matched for age, gender, and BMI. So they studied position sleep apnea patients, REM OSA, so patients who had OSA that occurred exclusively in REM, and control subjects without OSA. And this is what they found. So when you compare the lateral with the supine position, so when these subjects move from the lateral to the supine position, you see that there was no change in lung volume in FRC in the control subjects and in the REM OSA subjects. But however, if you take positional sleep apnea patients, there was a significant decrease in lung volume when they changed this position by about 340 milliliters. Another question we can address is whether it's the head position or the trunk position that really matters for positional sleep apnea. So you can have different combination, as you can see in this study. You can have trunk supine, head right or left, and trunk lateral with head right or left. And in this study, they compared the apnea-hypopnea index that you see on the y-axis with these different positions. So on the left, they compared the trunk supine, head supine with an AHI of 36 that went down to 25 when the trunk was supine, but the head lateral. So when you have your head not supine, apparently it decreases significantly, modestly, but significantly, the AHI. And when you compare trunk supine, head supine with trunk lateral, head lateral, you can see that there is even a much greater decrease in the AHI, suggesting that the trunk position is probably a little bit more important than the head position, maybe because of the lung volume problem that I mentioned. When we compare the complete supine with trunk supine head lateral in this population, they found that there was indeed a decrease in the global AHI, but this was mainly the case in patients with a BMI below 32. This suggests that when you're very obese or significantly obese with a BMI above 32, the effect of the positional is a bit less important. So there are still some open questions for which we don't have any final answer. First, is there an evolution in time between exclusively positional sleep apnea, and non-positional sleep apnea? Is it a continuum? So we need to have prospective studies to answer this question. Is the impact of positional sleep apnea on clinical outcomes, such as sleepiness, hypertension, cardiovascular events, for example, different than OSA in general? Again, we will need prospective studies to answer this question. And what is the impact of position treatment on these clinical outcomes? And there are current studies that are addressing this question. So in conclusion, we can say that positional sleep apnea is highly prevalent among OSA patients. For example, POSA represents about 56 to 75% of these patients, and exclusively positional sleep apnea can be found in 27 to 47 of these patients. So this means that about 1/3 of OSA patients could be treated successfully with a positional therapy. The main characteristics of positional sleep apnea are lower HI, so milder cases, lower BMI, and maybe a higher abdominal obesity, especially in men. So this concludes my part of the presentation, and it's my pleasure now to turn over to my colleagues and friend, Professor Nico de Vries, for the second part of this webinar. Thank you.
Well, thank you so much, Rafael, for this fantastic presentation. It's really a pleasure to listen to you. Let's continue with the second part. First of all, for those of you who cannot get enough of it, there's a whole book about positional therapy in OSA. But let's start with a short animation of development of OSA conceptually. Mild OSA, so early stage disease, beginning disease, is more often than not positional. So this average HI is composed of how you do it in left and right lateral position, supine position, and in case applicable, prone. Now, OSA is a progressive disease if you don't treat it. And what we then see in the course of time is that this HI goes up in the other sleep positions as well in moderate or severe OSA. So beginning disease is positional, severe disease is not. And as we see in a few minutes, this in fact is a reversible phenomenon. In partially effective treatment of severe non-positional OSA, you see reversal into less severe, again, positional OSA. And what positional therapy is just this elimination of the supine position. Another way to look at it is this. So again, 50% of patients with beginning disease are positional, and with increasing disease severity, the less positional they become. If you go in the other direction into simple snoring, so patients with an HI below 5 snorers, they are even in 70% positional. So there you express it in the snore index, and that snore index is in more than 70%, at least twice as high in supine position as compared to the other positions. So it is very fashionable at this time to talk about phenotype, the peak grids and the loop gains and muscle responsiveness. More or less deliberately provocative, different alternative phenotype would be positional versus non-positional patients. In the beginning, it is really very simple. It's just simple gravity. And the whole idea of positional therapy is not directly new. Already in the US during the War of Independence and 100 years ago in Europe, in the First World War, soldiers were already advised, don't sleep on your back when you're out there in the fields because you will snore louder and the enemy will know where you are, and that's not directly a good idea. And on the right side, you in fact see a soldier sleeping with his back to the trench, which is in fact positional therapy enfant la lettre. The first patent on positional therapy was filed by a person called Sullivan, not the same Sullivan of the CPAP, but apparently Sullivan is a good name for inventions in OSA. This led to what's now called old school positional therapy, variation of tennis balls, squash balls, backpacks, bulky masses, inflatable, whatever, put to the backside of your pyjama or t-shirt in order that you cannot sleep on your back. The problem with all tennis ball technique variations is the compliance. All long-term studies have shown that patients stop using it after some time. And that is because this is a very uncomfortable way of sleeping. Low compliance, uncomfortable, it disturbs sleep quality. And there are even patients who sleep on their back on that bulky mass, in which case it doesn't work and they wake up with pain in their back. So take home message number one is please forget old school tennis ball techniques. Then already some years ago in Amsterdam in the Netherlands, we started with a very primitive device which was worn in the neck, and it was a kind of proof of principle because this device actually worked. So what it did, it detected sleep position. As long as the patient was sleeping on the left or right side or prone, nothing happened. When the patient turned to his back, this device would give a very subtle vibrating stimulus, which was meant to give an arousal but not an awakening, so the patient would turn to his side without waking up. Again, a very primitive device. Then we came in contact with, at that time, a startup company called NightBalance, which had developed a very smart device, the sleep position trainer. And this is something that you wear on your trunk with a small device in it. The device records your sleep position. Again, when you sleep left, right, or prone, nothing happens, but when you turn on your back, a very subtle vibrating stimulus will appear, and with the intention that, again, the patient does not wake up and turns to his side. There is a start, a delay in it. There's a pause button. Every morning you can read it out. So which is my residual percentage of supine position? Is the percentage of corrections that I need, is that going down? So it's a very motivating thing for patients to see if that they are actually doing better. The studies that we have formed in the course of time with this sleep position trainer are actually convincing. So the first study by Peter van Manen from my group showed reduction of the AHI from 16 to 5. The mean percentage of supine sleeping position went down from 50 to 0. There was no change in sleep efficiency in the sleep studies. The ESS decreased significantly. Quality of life went up, and compliance was very high. So there are two definitions for compliance. The one is 4 hours, 5 days a week, or 4 hours, 7 days a week use. And depending on that definition, compliance was 92 or even 100%. The first days of use is actually training and data collection, which is the percentage of supine position. But after a week, the effect is always there, and you see clearly that there is only 6% residual supine position left during this treatment period. At the same time, in the Netherlands, there was another study in which the old-fashioned tennis ball technique was compared with the sleep position trainer, and the effect was, of course, more or less the same, but the compliance difference was substantial. Then the caregivers and healthcare providers asked us, okay, this is short-term, how is it for long-term? So at that time we did a long-term study in 18 different Dutch hospitals, and even after 6 months, the compliance was still at 60%. I have to stress here that it was a study in which we just gave the sleep position trainer no support or positive reinforcement programs. So here you have your device and see how it goes. And even then, in that system, there were the compliance was 60% after 6 months. As you see here, 60%, and clinically relevant improvements in the Epworth from 11 to 7, and improvement in quality of life after 6 months. Another very interesting thing is the combination of positional therapy and oral device therapy. This is a study that we performed in Antwerp. So at the left side, you see here moderately severe positional OSA. And you have a reduction of the AHI with exactly 50% with oral device therapy. Then these patients got, instead of the oral device, the sleep position trainer, and exactly the same improvement with 50%. And then we gave the combination, and it gave a further 50% reduction of the AHI. So this was for the first time that could be shown that this kind of combination therapy makes sense. I'm a sleep surgeon, so I'm also interested in what happens with sleep position and outcomes of surgery. Now, you might know that the most common surgery what used to be performed was the so-called UPPP, and there are more or less 70 different studies on results of UPPP. And only 4 of those have looked at sleep position. What you then see is that UPPP was most successful in decreasing the AHI in lateral position. In supine position, there was often no difference at all. So in other words, after surgery, this difference in AHI between lateral and supine position is more pronounced after this kind of surgery. So UPPP enhances the position effect of OSA. So additional positional therapy could improve outcome of this kind of surgeries. And in fact, we looked at that in a group of patients who had the partial effect of upper airway surgery. So as you will know, upper airway surgery is not always successful. This was a group of patients who dropped after surgery from 30 to 18. So there was improvement, not sufficient, but all those patients had become positional. So we added positional therapy to it, and there was a further drop from 18 to 12. So the combination was again from 30 to 12. Percentage of spine precision dropped to 7, Epworth dropped to 7, and compliance again was very high. We recently did a systematic review into the influence of positional therapy on surgical success. There are 9 studies looking at it, and the results are a little bit conflicting. Some studies show that there is no difference between non-positional and positional patients. Some say there is a better outcome in non-positional, and others say the other way around. We also have looked at it in patients undergoing bimaxillary advancement, so this really aggressive surgery by the maxillofacial surgeons. usually with a success rate of about 85%, but there is also 15% failure. Sometimes it is more useful to look into your failures than in your successes. And what you then see that this 15% failures is usually become positional. So here again, you can add positional therapy to this surgery. But another way that we looked at it is that there was a small group of patients who were positional, so PP is positional, and they had their Biomax, and there was, in that sense, no difference in outcome in positional and non-positional patients. And for sleep surgeons, these things are very important, because patients come into your office as, am I a candidate for upper airway surgery? Then you study the sleep study, you see that they're positional, and in case positional therapy is not an option or a failure, then you can still embark on upper airway surgery. Let's skip this one. Another important concept is that of a mean disease alleviation. You might be familiar with it, but the concept is that you can have treatment with a high efficacy, like CPAP, with a poor compliance. You compare it with, let's say, oral appliances with less efficacy but higher compliance, and the total effect in this example might be comparable. So this concept of high compliance with reasonable efficacy applies to positional therapy as well. Now in Amsterdam, we do a lot of bariatric surgeries, as in many places, but what makes it unique in Amsterdam is that we perform sleep studies in all patients, and 2 out of 3 patients who undergo bariatric surgery have OSA. Then we repeat the sleep study in those OSA patients after 6 to 9 months, and then you see the same phenomenon. Severe non-positional OSA decreases to less severe positional OSA. So also in those patients, additional positional therapy is a consideration. As a sleep surgeon, we always perform drug-induced sleep endoscopy before embarking on upper airway surgery or upper airway stimulation. And the old teaching was, let's do that in supine position, because then the obstruction is most pronounced. But since positional therapy is now one of our treatment options, it makes at least as much sense to perform this DICE in lateral and supine position. And in fact, we do now 4 assessments in both positions. We bring the lower jaw forward to jaw thrust, because we think that to a certain level that has some predictive value for what happens with oral devices and positional therapy and combination treatment. Another study that I would like to mention is RCT that we did, in which we compared the sleep position training with oral devices. There are 2 papers on it, the 3-month results and the 6-month result by Benoit and de Ruiter. And multicenter RCT, 99 patients, PhDs were repeated after 3 and 12 months. Primary outcome was HI, secondary outcomes HI supine position, percentage of supine position, compliance, mean disease alleviation, and subjective questionnaires. Inclusion was mild to moderate OSA with between 10 and 90% supine position, and again, HI supine should be at least twice as high as non-supine. 177 patients were assessed for eligibility, 78% were not eligible, so there were 99 patients left after this first part. And what you see here at the left side, that in the beginning there were much more dropouts in the oral device arm than in the positional arm. Interesting. But if you then go to the comparison, after 3 months and after 12 months, and in per protocol analysis and intention to treat analysis, there are no differences whatsoever between the sleep position trainer therapy and oral appliance therapy. Completely comparable outcomes. But if you look into adverse events, there are more adverse events in the oral device arm than in the sleep position trainer arm. In both groups, there is a certain percent of patients with persistent snoring or persistent tiredness. But if you look into the other side effects, there are much more side effects in the oral device patients than in the sleep position trainer arm. So conclusion of this study was that the sleep position trainer and oral device therapy are equally effective in reducing the AHI in both intention to treat and per protocol analysis at 3 and 12 months. Durability of the treatment effect of both treatments was good, and adherence was also high and similar in the two groups. So if we now try to define the ideal features of treatment of OSA or positional OSA, well, it should be effective, it should be well tolerated, so high compliance, ideally reversible. If there is any change in sleep quality, it should be improvement, no side effect, and acceptable costs. And I think we can conclude that this new generation positional therapy fulfills these criteria easily. So, final thoughts. Positional OSA is common. It can now be treated without disrupting sleep quality. This new sleep position technology is undervalued. The sleep position trainer in the Netherlands is now reimbursed since 2 years based on the studies that we done. We prescribe it a lot. And sleep position trainer has the potential to become fourth OSA therapy in addition to what we already have, CPAP oral devices and upper airway surgery, and you can use it alone or in a combination. Well, having said that, thank you for listening to me. I would like to give the word back to our moderator, and I'm more than happy to answer any questions that might have come up.
Thank you, both Professor Heinzer and Professor De Vries, for your very professional and informative presentations. And we've received numerous questions from the audience. However, before we get to those, I would like to tell people how to obtain their CE credits for attending. So for physicians, nurses, and respiratory therapists, this educational activity is approved for 1 contact hour. To obtain these CE credits, you need to go to saxtesting.com/BO. You will need to register at the site, complete the evaluation, and upon successful completion, you'll be able to print your certificate of completion. Support for this educational activity is provided by Philips. So, let's move on to the questions. So we have several questions from the audience that have come in over the last 40 minutes. The first question is from John, and this one is for Professor De Vries. And John asks that we see that POSA, or positional OSA, is common across several prevalence studies as presented by Professor Heinzer. But what is your experience of the prevalence in your clinical practice? Is positional OSA as common as these studies suggest?
Well, it's a very good question, and the answer is absolutely yes. Of course, it depends on your kind of practice. So let's say that you would see only severe OSA patients. You won't see that much positional patients as explained. But in the typical ENT practice, the majority of patients that you see are in the mild to moderate category, so they are often positional. So every day again, I see patients with positional OSA, and then we discuss the different treatment options like oral devices, surgery, or positional therapy. And when you explain it to patients, many patients will say, let's give it a try first with positional therapy. So it is probably for me now the most prescribed treatment option. It does not always work, and then you have all other treatment options still open, but it's absolutely a very valuable addition to the treatment armamentarium that we used to have.
Thank you, Professor De Vries. I'm going to pose now a common question we've received straight to Professor Heinzer. Professor Heinzer, can you diagnose positional OSA from a standard polysomnography or polygraphy test, or are additional tests or parameters necessary to do this?
Very good question. So it's highly possible. It's completely possible to diagnose position sleep apnea based on the usual PSG or polygraphy, so limited channel recorders that you can do even at home without having a full sleep lab, because this device records the position of your body, and so we just need to be careful to have enough time in the supine and in the non-supine position. I would say we would need at least 30 minutes in each position to be really able to diagnose sleep apnea, to make sure that we have a reliable AHI in both positions. The only thing that would be better with a polysomnography is that we have a camera, and the camera can really tell you if the patient is really in the supine position or mildly lateral. So this is even a little bit better with PSG, but it's completely possible with a portable monitor with a recording that is performed at home.
Thank you, Professor Heinzer. Professor De Vries, do you have any additional comments to add to that?
No, but it's important that you indeed have a kind of sleep study that records sleep position. That is not usual everywhere, but for this diagnosis, it's absolutely essential.
Excellent, thank you. So Rachel has posed a question for Professor De Vries. Rachel asks, why would you treat positional obstructive sleep apnea if these patients are not severely sleepy during the daytime?
Yeah. Now, you have to realize that patients come to see us because they have complaints. And sleepiness is not the only complaint that you can have of OSA. So there are patients who are tired or have lack of energy, or are loud snorers, are easily irritated. So there's a whole complex variety of complaints that you can have of OSA. And so it's not only the sleepiness. In this early stage disease, there are many patients whose main alarm symptom is this loud snoring. They are sent by the bed partner. The bed partner will tell you, if you ask them, indeed, the snoring and the apneas are much more pronounced when he sleeps on his back than in lateral position. So also in those patients, there are very good reasons to treat them. It is not only the sleepiness.
And Professor Heinzer, do you have any additional points to make on that question?
No, of course, from a medical point of view, it's really indicated to treat people with sleepiness, but many other people complain of the snoring, of choking at night, and maybe the spouse or the bed partner could also suffer. So even if it's not a purely medical indication, it will definitely help them to decrease their snoring and their sleep apnea with a positional device.
Thank you, Professor Heinzer. Deborah has asked a very interesting question, and she's asked this one directly to Professor Heinzer. Deborah's question is that considering positional OSA patients are young, leaner, and not severely sleepy during the daytime, are these a group that would naturally struggle to accept and use CPAP and MAD, or oral appliance therapy, more than the severer patients? And does this make them more suited to a less invasive, more comfortable treatment like positional therapy?
Yeah, thank you. This is very interesting. in my clinical practice, I would say that it's difficult to predict who will accept and who will tolerate CPAP or mandibular advancement devices. And it's not always the patients with a lower AHI that are the more reluctant to these treatments. So I think positional therapy obviously will be more efficient in patients with lower AHI because they have more chance to be exclusively positional. But I would also use it in patients with more severe sleep apnea, who have clearly positional sleep apnea and who don't tolerate CPAP or MAD.
Can I add something, Raphael? Because I totally agree with you, but it is also my experience that in mild OSA, young people, if you say to them, well, one of your options could be lifelong treatment with CPAP, they often say, well, I don't have that many complaints and it does not sound like a very good idea. And if then you can offer them a more patient-friendly alternative as positional therapy, they are often very happy to give that a try first. So I really believe this is a good example of personalized medicine. We have to move away from CPAP for everybody, and there's so much that you have to offer depending on the specific problem and needs of the particular patient and bed partner.
I agree. Many young people are reluctant to use, for example, CPAP because of the body image, and they are a little bit ashamed of that. And for them, definitely positional therapy, if they have positional OSA, is definitely a good option. I agree with you.
Okay, I think we have time for a few more questions. Gary has asked you both the following question. So what do patients subjectively report about active positional therapy with devices like the NightBalance device compared to what they report when using CPAP and oral appliances? Maybe let's start by asking that to Professor Heinzer first.
Okay, so surprisingly, the patients don't report being bothered by the vibration of the device. At first, when I saw the device, it's going to wake up the patient, and actually it generates just mild awakenings, and people often don't even remember this vibration. And it's much better than having an awakening at the end of each event, because it will only vibrate a few times per hour each time you're on the supine position. So they really tolerate it pretty well in my experience. I don't know, how about you, Nico?
No, I totally agree. Many patients, and what you really would like to hear is that patients say, I'm not sure if it was on even this night because it did not wake me up at all. And that's what you can see in your sleep study. You see arousal but not awakening. Patients stay in the same sleep stage while they still correct themselves. Of course, there are people who do not react well to it. There are patients who wake up, but that is not that often the case. Most patients have a good feeling about this. Indeed, if you compare it with side effects of oral devices, which is usually an alternative in early stage disease, but oral devices have the side effects of stiff jaws in the morning, dry mouth, or a lot of saliva in your mouth. The position of your teeth can change a little bit in the course of time, and we simply don't see that kind of side effects with positional therapy. Sometimes patients have shoulder problems, back problems, neck problems, so there might be contraindications, but they are quite rare, I would say.
Thank you both. That's very informative. Just time for one final question. We'll make it a quick one. And I'm going to ask this one to Professor De Vries only because positional therapy is reimbursed in the Netherlands. Several audience members have asked, where does this active positional therapy fit into routine clinical practice? Is it a first-line therapy? Is it a second-line therapy that you switch to when other treatments like CPAP and oral appliances aren't tolerated? What's the experience there?
Yeah, now the Netherlands is absolutely first line treatment on good indications. So if you are positional, you can give it a try with positional therapy first. It's totally accepted and usually preferred by patients. The struggle that we now have is that insurance companies usually say, well, if we have reimbursed one treatment, we're not going to reimburse another one as well. So you have patients who have a reasonable effect of oral device therapy and have changed into residual positional therapy. And then you see, well, if we could add positional therapy to it, then they would be really good. That is what we are facing now, but we will get there. The same as we have with upper airway surgery, patients do better but not supine, add positional therapy to it, and they are good. So it is really changing the whole field of treatment that we have to offer.
Thank you, Professor De Vries. Well, our hour is up. I'd like to thank everyone in the audience. Unfortunately, that is all the time we have for questions, but there were several more, and I hope we'll get the opportunity in the future to be able to answer them for you. Thank you to Professors Heinzer and De Vries for a most insightful and highly relevant presentation and a very, very professional delivery. At this time, I would like to turn the presentation back to Tracy for final comments.
Well, we would like to thank all of our presenters today for such an informative presentation, and Philips for their support for this educational activity. And on behalf of Sachs Healthcare Communications, Philips, and our presenters, thanks for joining us today, and have a great rest of your day.